Thank you, Chetan. Thank you, organizers, for two reasons. First, to give me this opportunity, and second, to have Dr. Bojes in my panel. So,
Hey, Dr. Sahoo,
I have read
what is it that you want from me?
I know that. So I read the whole yesterday. I read pathology of ovary, so that I can ask you some questions. So I told my friends here that in my whole DM preparing for DM, I never read this pathology ever. I read yesterday. Okay, ma'am. So let's have the poll questions first, and then we will go directly. I have 4 poll questions, and then we'll go directly to the case, and let's see what we can do best out of it. The first one is the pole mutations are most commonly seen in, these are the options. I think we can poll now. High grade serous carcinoma. Okay, let's see and find out what the answers are. Okay, next one would be the meta-analysis of neoadjuvant chemotherapy versus upfront surgery in ovarian cancer. Which of the following is true? They found survival benefit in favor of neoadjuvant chemotherapy. Most mortality was found in upfront surgery. Lesser stoma were required in the neoadjuvant arm, or all the above. Which is true? So all the above. Okay, let's come down to that when we have the slides there. So we go to the next one, third one, which is false about clear cell carcinoma of the ovary. Which is false about clear cell carcinoma. Stage 1 and 2 have high cure rates in comparison to 3 and 4. They respond to hormone therapy. They're usually positive for napsin A, and they are chemo-resistant tumors, which is false. B. Okay. So the last one. Which among the following is true about ovarian cancer? So I'm talking of the first line. Weekly taxane-based chemotherapy is better than once in 3 weeks taxane-based chemotherapy. Solo 1 included both BRCA positive and negative patient population as the inclusion criteria. Re-challenge with PARP inhibitors in 2022 has evidence backing it. Thrombocytopenia is common with olaparib. Which is of the following is true? E. Okay, so as per my answers, only one of the things was poll right, or we had maximum correction for one of the questions. Other 3 were not okay as the poll came out. Let's find out, and let's find out what we did right or wrong in the next panel. So I thank Dr. Amita Maheshwari. Some of her slides have been taken from her slides desk, so she is not here, but I have to thank her for a few slides which I'm going to use today. So we'll deep down into it. Now into a case which is a 57 years old upper socioeconomic strata lady, complains of abdominal distension, ECOG PS1. We have a CT scan which shows a moderate ascites, adnexal masses, omental thickening. There were liver surface deposits. There was no parenchymal deposits in the liver. The retroperitoneal node was 1 to 1.5 centimeters. So this were the few of the scan pictures what you can see here, and this was the investigation. The CA125 was 1158. The others were borderline normal or borderline high. So I'll first go down to my surgeon here. So would you operate this case as upfront surgery, or would you be comfortable for this patient load to go for a neoadjuvant therapy?
So in this particular patient, she is fairly good performance status, and her albumin is also fairly all right, and the CT shows nothing which is extremely unresectable.
Okay.
So I would consider her for an upfront surgery.
So you would consider for upfront surgery. My medical oncologist colleague, if it come to you and in your tumor board, would you have agreed and concurred with her, or would you have done that I would go for chemotherapy and do a surgery after that? Yeah.
So when the patient comes to the tumor board, we usually discuss whether it's upfront or operable. Yes, definitely no, there is a surgery followed by chemotherapy and NSCT followed by surgery. Like, in terms of survival, you are not harming. But looks like the liver deposit, then
It's a surface liver deposit, which
Yeah.
they can easily take out.
yeah. So what our surgeon colleagues have started doing now, they do because this patient has ascites and CA125 is very high.
Yeah.
They don't have the histopathological diagnosis. Maybe the ascitic fluid is positive.
It's positive.
But few of our surgeon colleagues have started doing the diagnostic lab.
Okay.
And if they calculate whether they can
Okay.
operate upfront or not. Based on that, we take a decision rather than just taking a decision surgery followed by chemotherapy or chemo followed by
Okay,
surgery.
I took out two meta-analysis, and this is the Cochrane analysis, which is in 2019, updated in 2021 also. It's chemotherapy versus surgery for initial treatment for advanced ovarian cancer. That's exactly what we're looking at for a stage 3 tumor. It looks at two things, and what strikes out is the OS and the PFS actually is not different. They're looking at the same OS and the PFS. But if you look at the other parameters, if you look at the adverse event, the infection, the post-op, recent complication, not the late ones. And if you look at the amount of intestinal dissection to be done or a stoma formation, if it comes to such patients, it is higher for the upfront surgery. So my question to the surgeon here would be, if I'm not doing any detrimental effect by giving neoadjuvant chemo, what is the harm with all the things, and meta-analysis after meta-analysis pointing towards one same thing, that if you do in this patient for stage 3, let's say, or stage 1 is different, I won't argue about that. What is the harm of going for a 3 to 6 cycles of chemotherapy and then operating, but we are not anyway taking away surgery? I hope the question is very clear.
Right, sir. There is absolutely no harm in going ahead with neoadjuvant chemotherapy. But when I looked at the images which were displayed, the mass is quite fairly large with a lot of cystic areas.
Okay.
There are chances that it might not respond as much as we would expect it to respond.
Okay.
And another thing that I noticed was that CA19 level, 99 levels were
Borderline,
high.
just borderline.
Yeah, so that could be a point in favor of the fact that this might be an endometrioid type of a tumor, or a tumor which might be a little less responsive to chemotherapy. So I would consider debulking this surgery, considering
So
looking
you
at the
still go
images,
for
it
it
looked
because of
awesome.
the reasons. Versus quick yes, no, what would be your approach in your tumor board?
So I feel if the surgeon feels this is upfront, easily operable with no major post-operative complications like multiple GI resections, I would let this
Okay.
patient be operated first.
See, this is the beauty of medical oncologists. We let others also do their job. Right? Yeah. So, the point is, if
Problem
you
is
look
when they
at,
do our job.
yeah, if you look
Problem
at,
is when they start doing our job.
if you look at hardcore evidence, I think whenever there is a ITR doubt, do not hesitate to give neoadjuvant chemotherapy. You are not doing any harm to the patient, and more so, your immediate complications would be much less surgically. There is no data till date to prove, but anyway, if a surgeon feels that they can go for a R0 optimal site reduction, nothing like it. So I think we'll stop here, but to tell you that whenever there is any doubt, or in centers which do not have a skilled gynec oncosurgeons, you would not be doing harm in such patient to go for a chemotherapy, improve the patient, and then send it for a surgery. So that would be my take-home message from me and the panel. Is that fair enough, madam?
Yes, I agree.
Okay. Okay, we go down. This patient had come to you, so you did that surgery. Optimal cytoreduction was done with no gross residual tissue. You did an optimal cytoreduction. So now come to the burning point, HIPEC. Would you go for a HIPEC? Would you refer it for a HIPEC?
Sir, as of now, there is no evidence in favor of HIPEC during a primary debulking setting. So for this
No.
patient, after a primary debulking, I would not do HIPEC.
If the patient would have been after 3 cycles of chemo and then you would have done the surgery, would you have then sent it for HIPEC?
I still have my reservations
You
about
have still a
HIPEC.
reservation. Fair enough.
So
And
under a trial setting, definitely.
okay, we leave that apart. Yeah, Bharat, you want to say something?
I think the histology is also important. If you are dealing with a mucinous, no, for high grade, I don't think there is evidence, and we should not be talking about HIPAC. So
We are coming to histology. We are coming to
Can you reduce the echo here? Because since yesterday we are dealing, there is a lot of echo going on in the auditorium,
Yeah,
and
so
we
I
cannot
can't
hear
hear
you
what
as
you're
well as
saying.
you cannot hear us.
There's echo when you are on the podium.
They
That's
have
what
an
I said.
echo in the mixer,
There's no
they can
echo there,
adjust
but,
that.
but podium ko par echo aa raha hai. So we're not able. Yeah, please. Okay. So HIPEC, anyone in this audience who considers
So we have
this case?
Snita here, and she was nodding the head. No, there is no role of HIPAC. Yeah, she was saying. Mike.
I can hear you. Yeah.
So, rightly put by Dr. Prabhu Desai that for primary debulking, after primary debulking, till now we don't have evidence for HIPEC. For after an interval site reduction, yes, there is a very strong rationale because you're doing a selective peritonectomy. You don't know that you have left behind microscopic disease in the areas that already had disease. So, HIPEC is going to be
Okay,
absolutely logical to take care
There's
of
an opinion from the
microscopic
house
disease.
that for the upfront, there is a Korean trial which is not published in the full text. It was a negative trial. We are looking at this, speaking of the Netherlands trial, and I'll come to that in a minute, why we should be skeptical about the trial. At this point, HIPEC is something which I agree, there are enthusiasts, HIPEC has its place, it will find its ground, but not for everyone. I'll point out that in a minute. But this is the trial I'm talking of. This trial result would really point out the Netherlands-based, the second trial, which is upfront 2026. I think this debate will be dying down whether we should be doing HIPEC in the upfront surgery or not. This is the Dutch trial which was published, and this trial, if you look at it, the techniques I'm not going to skip, I'm going to go into some intricacies, and this is something that is detrimental. If you like, it is approved. But before I go to the HIPEC, I have 2-3 things which we need to go for histology. Madam, if I come down to histology, and this patient was a high-grade serous, and all of us agree that most of these patients of ovarian cancer are high-grade serous. In your practical experience, what would you see, how many cases which come down to you for a second opinion have change in their histopathology report? I'll come down to that point first, and which are the varieties which one should be very, very careful to get reported from a good experienced pathologist.
Yeah, I think what you said over here is absolutely true, that 71% or anyway,
Yeah.
almost 2/3 of patients are serous adenocarcinomas. They are the usual variant of high-grade carcinomas. The other ones are what has been mentioned over here.
Which would be
And
the
I think-
variety that would change? Mostly you find a change in
well,
diagnosis when they come to you.
I think if you're talking about, very high CA 125 values, if you're thinking of HIPEC and you're thinking of all of these chemo-responsive type of tumors, then I think it's very important that we know that this is a high-grade serous adenocarcinoma. Now, it's very important that you get high-grade and you get low-grade serous adenocarcinomas.
Okay.
And the two things should be differentiated.
Okay.
Yes, you can't just say serous adenocarcinoma and, just treat it as such.
So a very clear-cut low versus high should be mentioned, and that one should at least look out for. A very question continuation this, if I have a small biopsy taken before starting a chemotherapy, we don't have the last issue, what are the high chances that low grade or high grade reported will be majorly a low grade serous carcinoma?
So it's unlikely,
Okay.
but this happens when you have, not necessarily when you have spread, because low-grade serous adenocarcinomas are very unlikely to have spread in the way that, and give rise to ascites and so on. It happens, but it happens in a very low percentage of cases. But if you have the ovarian mass, and that's the real sort of problem, you can get high-grade tumors and you get low-grade tumors, and I don't just mean serous. There is a whole group of high-grade tumors, nearly almost 70, no, I would say even 80% of them turn out to be high-grade serous carcinomas. And a lot of people quibble about whether this is high-grade endometrioid or high-grade serous. I don't think it makes that much difference when you're dealing with fairly localized ovarian tumors. They respond more or less the same way to...
Ma'am, coming to your last line which you told, this is a beautiful article pulled up maybe 5 years back, published, the algorithm of the ovarian carcinoma typing, and they looked at 8 markers, which there are usually 10 markers, but they took out 2 because it was not available in the market. They looked at WT1, the TP53, the napsin A.
No, that's available, of course.
Yeah, no, there were 2 more which they took out. So they took 8 here. My question was different. If you look at the graphs here, they found that the endometrioid carcinomas of the ovary but the most commonly in that group, 7% were misdiagnosed. And if you change the diagnosis to high-grade serous, the prognosis change.
Yeah,
So
but
what has been your practice and what do you say of this?
That's what I'm
part?
saying. See, the endometrioid carcinomas are, if they are really high grade, okay, you can get low grade and high grade endometrioid carcinomas. The intermediate grade moves with the low grade carcinomas. If they're really high grade, this is not about, high grade endometrioid carcinomas versus, what does it say over there, the in between line?
The high-grade serous carcinoma.
Yeah. So if you, I think people should be very careful, and we need the immunomarkers to tell you that this is serous.
Okay.
Particularly when you get a good WT1, a P53, etc. But that's not to say that P53 cannot be expressed in a high-grade endometrioid, because after all, P53 is just a progression marker.
Progression.
It's the WT1 that tells you whether this is serous, but it doesn't tell you whether this is low-grade serous or high-grade serous. So if you get a serous WT1, then please put on a P53, because low-grade serous will not express P53, but the high-grade ones will. But
So-
don't just go by P53, because P53 doesn't tell you whether this is serous or this is endometrioid.
So the take home here is, when you look at histopath, in a high grade, you expect the P53, 85 to 80 to 90% of the high grade serous are P53 positive, 5% only will be negative. The WT1 is the major marker which is positive in the serous, will be negative in endometrioid. That's one of the major differentiating points. You still can get a P53 high even in endometrioid around 20%. For a clear cell, the napsin really comes in, and that is the marker all of us look at apart from the PAX8 and a few other markers, and they are also WT1 negative. So this is something which I thought I'll just skip off, and I'm now going ahead. And if you look at this, the endometrioid variety of ovarian cancer, even look at the endometrial carcinoma which was previously discussed, we look at the pole mutation. These have a special variety which are very responsive to immune checkpoint inhibitors. So now, looking at the data which you looked at, the now the trial which I was looking at, for the HIPEC, very 1 minute, what is the data is that 50% of the patient for this trial came from the Netherlands Cancer Institute, which did not show a beneficial effect. Actually, the other 50% contributed by the other centers across the 8 countries which contributed to this actually pushed the benefit. It does matter, because when you're saying it's a skilled labor and people who contributed 2 or 3 cases in the whole series of 200 odd, and then that group only pushed that data, that is something that needs to be looked at. Was the surgery done adequately? That's point number 1. Point number 2, if you look at the population and the hazards, the PFS which was estimated, actually it halved down, and then the statistical analysis, that's why is flawed, because the initial versus the what actually happened, and the PFS was estimated and really that delivered was actually 50%. Apart from this, there are a few more, and you can get review articles about this. I'll just skip this point to a point for discussion, because a lot of things to discuss. HIPEC is there. It has to find its place. It should not be done for all cases. Upfront HIPEC at this point does not have a level 1 evidence. The best evidence as of date is for a neoadjuvant based approach, where this Netherlands data really saves you, but that data should be crunched, read through properly, with criticism taken, and then we should move ahead. But it is a tool which has to be there in the armamentarium for us to use it. So I think I made your point. I'll move on.
No, you haven't, but in the interest of time, yes.
We will do HIPEC 1 minute after the panel is over, because I know there are a lot more things. And this is a topic which is very, very close to hearts. Yeah. So now, adjuvant therapy. Now come to a medical oncologist. Do you test for BRCA for all comers? Do you leave out mucinous varieties because you very unlikely get a BRCA? Vasist, what is your take on that?
So typically I do it for all comers, sir.
So you do it for all
Yes,
comers?
mucinous itself is an extremely rare tumor seen in less than 5% of patients.
Okay.
Typically all comers.
But you do it for all comers?
Yes.
And you do it germline or somatic, and then you
So,
do the vice versa?
We do a germline BRCA and a HRD, which should cover a somatic BRCA.
So you
as
do
well.
a germline and HRD.
That's
If you do HRD alone and then do a germline, because you are doing HRD anyway.
I would do it anyways because both have different conundrums. If you have a germline, I mean, I would still want to screen for a germline for the family.
Yeah, if
as
it's
well.
a positive, then definitely you're going to screen
Yeah.
for germline.
Yeah,
That's my
but
point.
even if it's an HRD is a negative, I would still do a germline BRCA.
Yeah, okay, fair enough. So, Bharat, mucinous, because the data, if you look at in literature, 0 to 1 to 2% or even 0% is most literatures. Would you take out mucinous or you will just do everyone?
So in a clinical practice, a
Yeah.
real world clinical practice, we discuss but don't do it for all because there are logistical implications. But yes, for high grade serous, it should be advised to all, especially those who have strong family history, younger age. Mucinous I don't practice.
Take home should be, you can offer it to all. That's what the literature says. Mucinous, you're unlikely to get it. It's less than even 2% or 1%, even some literature told around 0%. So that is how the take home should be. But yes, if you do it as Vasist does it, nothing wrong about it. So is it NGS or NGS plus MLPA? Bharat?
So not the broader panels. We have precise panels of 10 to 15 genes which can cover those important genes, not the whole NGS.
Vasist?
There is a element of cost to this as well. An NGS plus an MLPA is around 35 to 40,000. Where
That's
a
okay.
plain
Olaparib
NGS
is
only
way
20.
costlier than that.
Yeah, so Olaparib, as we know, is not afforded. I mean, only less than 10% of patients would eventually be on maintenance Olaparib. And amongst the ones who can afford also, as a medical oncologist, I think Dr. Bharat will agree that we ourselves are very uncomfortable prescribing to all comers who are HRD or BRCA positive. So I think cost does matter to an extent, but if there is a family history, high likelihood that this is going to be positive, I would want to do an NGS plus MLPA to have a higher throughput.
So again, the take home should be that if you are doing it, I am very clearly convinced that it should be NGS plus MLPA because you are going to lose out those the broad 20 nucleotide panels which will not be picked up on the NGS. So if one is doing it, be sure you understand the technique and you have to complete the panel because you are doing it for a specific mutation and you have to get it to another 10-15,000. To my mind, would not mind for a patient who anyway is going to spend lakhs on the treatment what you are going to plan. So HRD I'm going to skip, but all of us agree it has to be done. So now to my medical oncologist. For this patient, if it is a BRCA positive, would you do a BEV plus Ola? Would you do a Olaparib alone? Or would you do a BEV followed by Olaparib? Bharat?
So before also in my practice, I have not a bigger fan for bevacizumab because it has never showed us ultimate overall survival advantage. Yes, there is some PFS advantage, but that is also in the first 12 months to 18 months.
If you have a high risk, suboptimally
so
reduced
if somebody is
stage
definitely, I feel so going for best possible therapy and can afford, then it's my job to discuss all the possible options available.
What are you convinced
So
about?
bevacizumab, if it is used along with from the first cycle, then only, otherwise using
So you would
monotherapy.
not use it after the chemotherapy and just add Olaparib and BEV?
Yeah, so if the patient is positive and patient has finished all the cycles, either neoadjuvant had good response or adjuvant and then completed 6 cycles and patient high risk, then definitely one should discuss because adding Olaparib gives a good number of the 70% reduction in the risk of progression as well as death.
Persist, any different take on that?
So first line maintenance, BRCA positive, I use single agent PARP inhibitor. My experience of combining Olaparib with BEV is a lot of toxicities and most patients do not end up finishing the
So if
duration.
someone has taken a BEV and a chemotherapy because it was suboptimally reduced as per the ICON high risk criteria or a stage 4 which was given neoadjuvant chemotherapy and then operated, that gives indication for BEV. That's the only
correct.
indication.
We reserve BEV for suboptimally
So if
saturated.
patient has taken BEV with chemo, would you stop BEV and then go for Olaparib?
No,
Okay.
no.
So anyone in the house
So
does
in
different?
that case, I think both should be used rather than using monotherapy.
So the point here the panel is making is if you have used BEV for indication of BEV in the high risk category, that is a stage 4 or suboptimally reduced, then those patients you have data from Paula to tell you that you can use a BEV plus Olaparib. Stop BEV at 15 months. That's what it is. Do not extend the duration of BEV. There is no extra benefit of the extra thing that came out last year. That extra BEV does not add much. The Olaparib continues, but if you have not done during chemotherapy, there is no justification to add a BEV and a PARP inhibitor, although they look similar, they enhance each other activity in the lab, but that has not been found so in the clinics. So that's where it is. So now this patient, I'll just ask that because there's a poll question, I just want my panel to come in. If the surgeon has operated, would you do paclitaxel once in 3 weeks, once a week, or would you add chemotherapy with BEV? It was, mind you, a stage 3, optimally sat reduced.
The preference is for 3 weekly chemotherapy because the outcome is equal. Even for the geriatric population, there is a data of single agent platinum versus weekly versus 3 weekly, which has shown that 3 weekly is better.
Okay.
For good performance status patients, I use 3 weekly. Yes, there are patients whom you have to modify, but in that case, weekly pacli carbo, that is weekly 60 milligram pacli and AUC2, that is preferred as compared to that 80 milligram day 1, day 15.
So the evidence is that there was a SWOG trial which really pointed out, and really the Japanese trial, which was the popular trial which we used weekly, then the SWOG pulled out that 3 weekly is better. The Japanese are a different subset. If you look that out, in a bigger randomized, more heterogeneous population, 3 weekly has shown to be better than a weekly. But one thing that has come out as subset, again you can go back and I think about it, I'm not telling you to practice it. The patient who took a weekly paclitaxel, in that small subset of patients, 50 odd patients in that SWOG, they did have the benefit as the addition of BEV. So I always told that time 4 years back, is it a poor man's bevacizumab, the weekly pacli, the anti-angiogenic effect? But do not practice on this evidence. That is something to think about, that weekly paclitaxel has that trial showed in the subset, not a planned one, that there was a similar benefit to a 3 weekly paclitaxel plus BEV. So moving on, I'll just go through it. Your choice for this patient, olaparib, or now we have rucaparib now. What do you think, which should be your option? Can I have the surgeon's thinking also? What do you feel? What should be your opinion here? Because now this is a BRCA positive.
So now that she's BRCA positive, definitely a PARP inhibitor.
That's for sure.
For
Which one?
sure. The evidence as of now available is for olaparib.
Okay.
But
Let's think what a medical oncologist thinks. Yeah, please, sir, Vasis first.
Ola plus BEV has the best data.
You did not give BEV.
Sorry,
You did
not
not
use
give-
BEV, single agent olaparib. Rucaparib, we currently do not have data to use it in the first line setting. There is one Athena mono trial where data is available, but as of now it's not robust enough to be recommended in the first line
So
setting.
you are going with olaparib.
Yes.
BEV use Ola plus BEV. Bharat,
Yes.
any difference of choices?
Agree with Vashist, what he said.
You are agreeing.
Olaparib.
Chetan, rucaparib, you would do for it? Not yet? No? You are not convinced about yeah. Amol? So you feel all the PARPs are made similar?
Yes. And if there is a generic version available, I don't think so there will be wrong to offer that, especially if the cost constraints are there. And now that we have Athena mono
Madam.
data also.
Madam, your choice. You have the final say on that. With the Athena now in Athena mono, do you feel that with the with Indian cost of the PARP, rucaparib is little cheaper than olaparib? Are we okay
It is
with
significantly cheaper. Significantly cheaper.
Yeah, I know that. That's the main question.
I'm quite comfortable using rucaparib.
Okay. So this question I brought up is with the publication, although with the criticism which Amol and me spoke about, the 4:1 randomization which happened. But if you look at the benefit and the hazards, it's similar to what you see in the solo and the other trials, the 0.3 to 0.4 benefit with the rucaparib first line. So till now we had rucaparib for the second line. This is one first time we have a trial, although the numbers of 400 odd, 4:1 randomization, we still have data for that. So I think we should be discussing it. We may be more convinced of olaparib, but this data is there now. And most of us believe that all PARPs are going to be having similar because the hazards is exactly the similar. So I'll just skip this. I think these are the 4 trials all of us knew. Yeah, I'll come to you.
Yeah.
And this is the different way of looking at it. Solo was the only one which had a BRCA positive as a inclusion criteria. The others were all comers. And then it showed that the HRD positive or the BRCA positive actually were the patients who benefited the most. The other group did not benefit and did not justify the addition of a PARP, at least cost-wise for Indian patient. Vasist, your take.
So, a very quick point. I wanted, since this is a composite population of oncologists, we get calls from a lot of surgical oncology colleagues. This is BRCA positive. Why have you not written olaparib? We can ask all the medical oncologists here, how many of their patients whom you have started on olaparib have finished 2 years? Question number one. Question number two, is the toxicity so easy? Let's not forget that these patients have undergone a major surgery, have undergone 6 cycles of chemotherapy, and now you're expecting them to continue a therapy for 2 more years.
Okay.
So there is a lot of fatigue.
See, okay, this is the trial I was speaking about, the Athena Mono. And I'll just go fast because we have been, I've taken 1 extra minute just for this. Okay, so I'll just skip this. This is the toxicity, which you are speaking of. And if you look at it, fatigue and anemia is a very common toxicity, but people have used more of olaparib. My friends have told that it takes, it's okay in 6 months. 6 months they settle down, and then you can really good look into that. But if you look at thrombocytopenia, is more with the niraparib. That was one of the, again, poll question which we asked. Okay, so I'll just skip off just one more thing. Last thing I want to the surgeons, and then I'll stop. The secondary saturated surgery. Do you think that we have a role for it? And do you think if I use BEV after your surgery, do I need to do that? Because the GOG told that if you have used BEV, the benefit is not there much. So what is your take on secondary cytoreductive? And then we stop here.
So secondary cytoreductive surgeries definitely has a role in properly selected cases.
What would be those?
First of all, the performance status of the patient, that has to be good. She should be able to tolerate a surgery which has been planned, and oligometastasis or single site diseases are preferable, especially if they've had a very good disease.
So basically, you have to super select the patient, no ascites. PET scan should having the limited disease, more 2 to 4 maybe, which patient surgeon can achieve a R0 resection. You should be looking at the time interval from the relapse. That's also very, very important, apart from the performance status and the stage of the initial stage of the patient. If you look at the SOC trial, there were 6 criteria which they looked into, and the PET scan. And that was what I feel will be the best way, no ascites. That's something which you should be doing the second cytoreduction. So I will just stop here and take the take-home slides. Discuss the tumor board discussion is very important for ovarian cancer. HIPEC evidence is still lacking, at least in the primary setup, and after the neoadjuvant, you do have some evidence, although we can criticize it. Once in 3 weekly paclitaxel is the standard of care, and apart from that, bevacizumab only for the high-risk group. PAP for all comers, I'm still skeptical, although the last rucaparib trial got approved, has positive for all comers, but still the benefit is very minimal. Definitely for HRD positive, definitely for BRCA positive. Kindly look at the inclusion criteria for every trial, criticize the trial, look at the graphs, and then only start practicing, because these drugs are going to cost a ton to our patients. So I hope that is where we stop, and thank you organizers for giving us the opportunity. I hope I made some points here. Thank you. Thank you, panelists.